I'd like to thank the organisers of this meeting for asking me to speak on von Willebrand disease, my favourite topic, in particular on new tests for diagnosis. My name is Emmanuel Favaloro. I'm from the Sydney Centres for Thrombosis and Haemostasis at Westmead Hospital, and there's my email address should you wish to communicate with me. So I have no disclosures to make. Von Willebrand disease is the most common inherited bleeding disorder. It's actually more common than haemophilia A, but it's less well known. And it's due to a loss of von Willebrand factor and or its function. There are three main types of von Willebrand disease. Type 1 von Willebrand disease, where you have loss of von Willebrand factor, but the von Willebrand factor that remains has normal function. Type 2, where you have a loss of von Willebrand factor function, with or without a loss of VWF of level. And there are four subtypes of type 2, and I'll speak about those in the next slide. And then you have type 3, where there is no von Willebrand produced. And type 3 von Willebrand disease is the most serious or severe form of von Willebrand disease. In type 2 von Willebrand disease, there are four subtypes. You have type 2A, where you have a loss of high molecular weight, VWF, and high molecular weight VWF is the most adhesive form of von Willebrand factor, or the most functional. In 2B, you have a hyperadhesive form of von Willebrand factor, where VWF binds spontaneously to platelets, leading to clearance of high molecular weight VWF and also platelets, so you might get a mild thrombocytopenia. In 2N, von Willebrand disease, you have a loss of factor VIII binding, so the factor VIII degrades very quickly, so you have a low level of plasma factor VIII. And 2M, where you have a loss of von Willebrand factor function that's not associated with a loss of high molecular weight VWF. A lot of people have difficulty with the 2M type. Essentially, it's a diagnosis of exclusion. So if you don't have type 1, type 2A, 2B, 2N, or type 3, then by definition, you have type 2M. So von Willebrand factor is an adhesive plasma protein that has binding sites for various agonists, various ligands. You have a binding site for platelet glycoprotein 1B, the VWF receptor on platelets. You also have binding sites for collagen, and also platelet sites, binding sites for factor VIII. So all these binding sites contribute to the functionality of von Willebrand factor. And if you have a deficiency of von Willebrand factor or defect in von Willebrand factor, then you have bleeding because you have von Willebrand disease. And on the right, I'm just showing you a simple cartoon where you have platelets attaching to the site of vascular injury, because the platelets will bind to von Willebrand factor, which binds to the collagen subendothelial matrix component, and it will arrest platelets at that site of injury, and then you get a formation of a platelet plug through formation of von Willebrand bridging platelets to damaged endothelium and also to each other. So if we look at the global pattern of bleeding disorder reporting, this is data from the World Federation for Haemophilia Annual Global Report 2021. And on the right, I'm showing you a graph which suggests the percentage of estimated that are reported in different countries. And if you look at developed countries, and the reported level of estimated is actually very close. In other words, the reported numbers of patients with bleeding disorders are very close to the estimated level of patients with bleeding disorders in those countries. For example, in Australia, we have 100% of the estimated reported to the World Federation for Haemophilia. In developing or Asia Pacific, and sometimes in Middle Eastern countries, there's a potential for underreporting of bleeding disorders. So I've just shown you some example of countries there, and Saudi Arabia is shown in the red bar. If you look at the global pattern of von Willebrand disease diagnosis, it's similar. So in developed countries, we have similar levels of von Willebrand disease and haemophilia reported. So the ratio of haemophilia to von Willebrand disease is approximately 1. In developing countries, Asia Pacific countries, Middle Eastern countries, the number of patients with haemophilia reported is much greater than that of von Willebrand disease. So the ratio inevitably is greater than 1. In some of those countries, for example, in Indonesia, the ratio can reach up to 150. And I've also shown Saudi Arabia in that graph as well. If we look at the main assays that are used to diagnose von Willebrand disease, I've just shown you a table here. You have factor VIII coagulant, you have von Willebrand factor antigen, and then you have a number of activity-based assays. The glycoprotein 1B binding activity assays that include racine cofactor, glycoprotein 1B binding using recombinant glycoprotein 1B, glycoprotein 1B binding using recombinant mutant glycoprotein 1B, von Willebrand factor collagen binding, factor VIII binding assay, And then you have the classical risk-induced platelet aggregation, and also you have multimers, VWF multimers. And I'll talk about some of those, in particular the newer assays, the glycoprotein 1b binding activity assays, and collagen binding using an AccuStar assay. In terms of guidelines, there are a number of guidelines now available, with the latest guidelines published in Blood Advances in 2021 by James et al. And they differ in terms of the recommended test panels, initial test panels. The US guidelines and the latest guidelines recommend an initial 3-test panel. The British guidelines recommend an initial 4-test panel. In our laboratory, we actually use an initial 4-test panel, and that is our actual recommendation as well. The guidelines also differ in terms of the cutoff for type 1 versus type 2, being 0.5, 0.6, or 0.7. And they also differ in terms of the test panels that are recommended by those guidelines. And I'll briefly talk about, in particular, the latest guidelines. So the latest guidelines actually have an algorithm which they proposed that laboratories use. I won't talk about this algorithm. We don't particularly follow this algorithm because we use a 4-test panel, not a 3-test panel. And I'll talk a little bit about that as well. In terms of some of the recommendations, I'm only showing selective recommendations from the guidelines. One of the recommendations that they suggest you using in the newer assays that measure the platelet binding activity of von Willebrand factor, in other words, the glycoprotein 1bm, the glycoprotein 1br, over the risk-seeking cofactor assay, automated or not automated for von Willebrand diagnosis. Another recommendation is that they suggest against using a platelet-dependent VWF activity to antigen cutoff of 0.5, instead using a cutoff of 0.7. In our laboratory, we actually use a cutoff of 0.6. And that would be our recommendation, unless you could see that 0.7 is actually better. They also suggest using either von Willebrand factor multimer analysis or collagen binding to antigen ratio to help diagnose type 2 von Willebrand disease for patients who are suspected of type 2A, 2B, or 2M, and we think that's a good recommendation. They suggest targeted genetic testing over low-dose risk-induced platelet aggregation to diagnose 2B von Willebrand disease for patients suspected of type 2A or 2B in need of additional testing. We think that can use RIPA analysis, and we actually use RIPA analysis and mixing studies ahead of genetic studies in our laboratories. And genetic studies are not always available in all countries. And they also suggest using either a factor binding assay or targeted genetic testing whenever available for suspected 2N von Willebrand disease, and we think that's a good recommendation. So before I talk about some of the new assays, I think it's important to talk about some of the older assays and some of the standard assays. BWF antigen, historically performed by ELISA, now mostly by latex nation, and that's an example I'm showing on the card on the right. Sometimes on the AccuStar, for example, is performed in our laboratory. Now, von Willebrand factor antigen provides an estimate of the level of von Willebrand factor in plasma, and every lab that tests the von Willebrand disease should perform this assay. However, it has limited utility on its own. A normal VWF antigen does not exclude von Willebrand disease, and indeed some type 2M, 2B, and platelet type von Willebrand disease will have normal levels of VWF antigen. And an abnormal von Willebrand factor antigen does tell you what type of von Willebrand disease it is. It may be a type 1 or type 2. So you must also perform assays for VWF activity. So the first class of assays is the glycoprotein 1b binding assays, typically performed as agglutination assays. Sometimes you can perform other systems, for example, AccuStar. And there are now three different types of assays. The classical receptor cofactor assay, the glycoprotein 1br, recombinant, and the glycoprotein 1m, mutant. They're all binding assays. Glycoprotein 1b binding assays. And every lab that tests von Willebrand disease should perform one of these assays. However, these have limited utility on their own. A normal level may not exclude all forms of von Willebrand disease, for example, 2B and platelet type von Willebrand disease. Some patients will give normal levels of glycoprotein 1b binding. And an abnormal level doesn't tell you what type of von Willebrand disease you have. You may have type 1 or type 2. So you must also perform levels for VWF, so antigen and factor VIII at the minimum. So the
So
first
the first of the
glycopyrene
glycopyrene
1B
1B
binding assays is the classical
receiving
cofactor
cofactor assay,
and I was showing you a cartoon on the right. So typically performed as a platelet agglutination assay. So platelets have on their surface glycopyrene 1B. You add ricocedin, that unfolds the vomitive factor in plasma, and then you get agglutination based on the functionality of the vomitive factor or proportional to the high molecular weight VWF. Historically was performed on platelet hygrometers and now increasingly performed by automated analyzers. Historically has a high assay variability and poor low BWF level sensitivity, and the latest guidelines actually recommend that you use a more modern alternative to glycopyrene 1BR or the glycopyrene 1BM. So the first of these, the glycopyrene 1BR, typically performed as a latex agglutination assay, can also be performed on the AccuStar. Theoretically has lower assay variability and possibly better low BWF sensitivity than certain cofactor. And it's recommended, as I indicated, by the latest BWD diagnosis guidelines. And I'm showing you a cartoon on the right, the way that this assay is performed as an agglutination assay. The other assay is a more modern alternative, is the glycopyrene 1BM, which stands for mutant. So this is a gain of function glycopyrene 1B that's used in this assay. Typically performed by latex agglutination assay, particularly if you're talking about the commercial automated assay, but sometimes can be performed as an ELISA. Theoretically has lower assay variability and possibly better low BWF sensitivity than certain cofactor. And in theory, there are no false low levels or low values, BWF polymorphisms that sometimes affect glycoprotein, sometimes affect receipt and binding. And as I said, it's recommended by the latest BWD diagnosis guidelines. I'm showing you the cartoon on the right, the automated process, the automated glycopyrene 1BM assay. Then another assay, it's a BWF collagen binding assay. Typically performed by ELISA, informed in our laboratory on the AccuStar, and I'm showing you the AccuStar on the right, and the methodology in the cartoon on the right as well. And it's important to note this is actually an additional marker of BWF activity. And there's also the in vivo correlate, BWF tissue binding will immobilize platelets at the site of injury. So in our laboratory and our recommendation is that this assay should be performed. Also will help detect the occasional rare BWF variants that are not detected using a three-test panel. And it also reduces diagnostic errors of a three-test associated with the three-test panel. I'll show you some data in a little while. Now, it can be performed selectively or at in other words, at a central site. If you have a laboratory, that's great. If not performed, then you need additional strategies to circumvent diagnostic errors using three-test panels. So one of the problems with formula brand factor testing is the lower limit of BWF detection in the assay. So some of the assays, in particular the routine cofactor assays I'm showing you on the right, cannot detect levels less than 10 units per deciliter. In other words, labs who have these assays cannot distinguish formula brand disease type 3 from severe type 1 or 2A formula brand disease. And it also affects BWF activity and calculation. So it compromises the detection of high molecular weight, deficient or qualitative defects such as 2A, 2M, and 2B formula brand disease. And the clear methodology performed on the AccuStar has the best lower limit detection. It can actually get down to less than 1 unit per deciliter, which is similar to what's in a factor VIII assay for hemophilia. Another main problem with assays and formula brand factor are assay variabilities. And this cartoon on the right is showing you some of the variability. Some assays are much more variable than others. And again, the routine cofactor is one of the more variable assays. But also in our study, the glycopyrene 1BM was quite variable, and also the collagen binding performed by ELISA is quite variable. But the least variable assays are those performed on the AccuStar or the clear methodology. And if you have a highly variable assay, then that leads to forced BWF activity to antigen concordance in type 2 and also forced discordance in type 1. And again, I said that clear is the least variable. This is similar slide to the other previous slide, but I'm showing you now the assay variability in type 2 formula brand disease testing, and it's actually worse than in type 1. And again, the more variable the assay, the worse for type 1 versus type 2 vulnerable disease discrimination. And again, the clear methodology has the least variability, and that's shown on the green in the figure on the right. But some assays are quite variable. We're seeing cofactor assay, even the modern alternatives to glycoprotein 1B-R and glycoprotein 1B-M are also quite variable in type 2 vulnerable disease. Just a point that assay variability depends to some extent on the level of vulnerable factor. So the lower the level of vulnerable factor, then the higher the assay variability. And it helps to explain why there's greater variability in type 2 vulnerable disease, because in type 2 the VWF antigen is often above 20% or 20 units per deciliter, but the activity is often lower than 20 units per deciliter. I'm just showing you one slide on the optimal cutoff values for ratio. As I indicated, the latest guidelines suggest a ratio of 0.7 preferred to 0.5. We also agree that 0.7 is preferred to 0.5, but we use 0.6, and that's the ratio that's recommended by the UK guidelines. And that seems to work better with our methodology, which is a clear methodology. And in the RSPA QAP data, we could see complete separation of type 1 versus type 2 vulnerable disease cohorts using a clear methodology and a cutoff of 0.6, and that clear separation was not achieved using any other assay combination. Question about 3 versus 4 test panel. As indicated, the latest guidelines suggest an initial 3 test panel. We recommend an initial 4 test panel. And if you use a 3 test panel, you're going to have a higher rate of errors than if you use a 4 test panel, about twice the error rate. It also depends on the type of vulnerable disease. The error rate for type 2, misinterpreted as type 1, for a 3 test panel is almost is as high as 15 or 20%. So use a 4 test panel, you get much lower error rates. In terms of the best methodology, I think it's without doubt now that we recommend that the clear methodology has the best methodology. And overall in this data that I'm showing you, there were no errors associated with VWF antigen and collagen binding in the RSPA QAP data over the last 10 or so years, and only one error for glycoprotein 1B-R when performed as a clear methodology. And that compares to an extensive number of errors, 116 errors for type 2, misidentified as type 1, and 35 errors for type 1 misidentified as type 2, and all of those were due to other methodologies, not to clear methodology, except for one error. Just lastly, I just want to mention that there are new methodologies also for VWF multimers. This shows some VWF multimers from our laboratory. I won't go through it other than to say this is a methodology using an instrument. So it's a semi-automated methodology, and it also can provide a semi-quantitative data. And this is actually a very good and reproducible methodology, and it's performed on a HydraSys system. This is just a slide showing you our own algorithm. I'm not going to go through it. It's available, and I'm happy to share a copy of this algorithm to anybody who wishes to see it. Just send me an email. I will say one thing about post-analytical. So laboratories often have difficulty in interpreting their own results. So one of the issues that we found in the RSPA QAP data is that laboratories have a problem actually interpreting their own data. This is a particular problem for type 2 vulnerable disease, where laboratories actually misinterpreted type 2 pattern that they actually found by testing as type 1 vulnerable disease, and it was responsible for about 40% of all type 2 vulnerable disease. So this is an educational issue. So you need to be aware of interpretation of your test patterns appropriately. That's the end of my talk. I'm sorry that I've had to rush through the talk. You know, there was only 20 minutes that I was given to talk about newer methodologies, but I'm happy to answer any questions at the question time. Again, thank you very much for inviting me, and thank you very much for listening to me.